presentations this afternoon is Dr. Kartik Iyer, and Kartik is from the University of Queensland. He's going to be talking about measuring cortical activity to predict improvement in anomia therapy following post-stroke aphasia. Thanks, Kartik.
Thank you, everyone, and thanks to Professor Dave Copeland and Professor Katie Mann for encouraging me to analyse this data set. I really have two motivations, overarching motivations, and two aims for this study as well. My sort of background is biomedical engineering and computational neuroscience, and I'm really interested in analysing brain activity and correlating to see how we can predict response to therapy. And particularly for this study, we looked at the role of EEG activity or cortical activity measured at the scalp to really establish what kind of brain mechanisms are involved in language improvement pre and post treatment. The second aim is, of course, to introduce a potential tool to neurorehabilitation in aphasia, and this technique is known as DCM. And of course, it sounds a little bit complex, and certainly has a complex framework that it works from. But what I hope to show and demonstrate is that the outcomes from this tool can really be simple and translatable to the clinic. What I'll present today is just a sort of a collection of the methods and results from the study, and then summarise on some of the future avenues and limitations as well. The subject cohort that we focused on was a small sample size of 8 patients at the chronic stage. They had a left hemisphere, all had a single left hemisphere stroke, and we also had 15 age-matched controls participate in the trial as a baseline. And a little bit about the task itself. So I don't have much background in speech pathology or aphasia rehabilitation. But I'll try and do this justice. But it was basically a simple picture word task involving semantically related incongruent items and congruent items, and also a collection of phonologically related incongruent and congruent items as well. And so we had participants both in controls and in aphasia have EEG recorded while they performed this task, and their responses were recorded and analysed. And following the pre-treatment EEG, they went through a therapy course of 4 weeks where they were asked to name items, producing features from either a semantic or phonological feature. And the outcomes that we assessed for this study was the semantic feature analysis and the phonological component analysis. And these outcomes were basically what we correlated against with the EEG measures. A couple of other things in relation to this. The behavioural measures have been established in previous studies as well, so I would welcome you to have a read of those, but this presentation really just focuses on these treatment outcomes, SFA and PCA to EEG. Okay, so why EEG? Well, I really like to relate EEG to the parable of the ugly duckling, because EEG's been around for decades, and really the use of it in a brain injury setting has been in the acute time window, where a lot of cortical activity at the scalp can be detected and characterised. But I think many of you would be familiar with the ugly duckling story. Spoiler alert, it turns out pretty good for this duckling. But EEG, I think in the last couple of years there has been a lot of advances in computational methodologies, and we can actually convert this scalp-based electrical activity to a more functional form using a method called source reconstruction. It's a mathematical technique, but utilises a lot of neuroimaging as well. And basically, it's converting an EEG to a more functional form. So things that we can often associate with, patients being in an fMRI scanner and performing language tasks. Well, with EEG we can perform the same sort of composite measures as well. And I think EEG is of course an untapped resource because EEG records at a very fast sampling rate, and of course language processing is at a millisecond level as well. So there's a great potential to utilise EEG more in a therapy setting, and hopefully the results of this study encourage people in those settings to utilise this tool. So the first, I guess, result that we got out of our study was to look at how people were responding to tasks. And we first established how healthy controls were performing on this semantic and phonological task paradigm. And we looked at two time windows associated with those tasks. And we can see that there are some very clear activations going on both sides of the brain. So certainly left hemisphere areas associated with language, and also right hemisphere areas as well. And of course in the aphasia cohort, you can see that there are some much lower level activations going on. So, and this was pre-therapy for aphasia shown. And all the sort of the blobs that you see on the screen, they are type 1 error corrected. So what we can be confident about is that this is actually task-related activity, not just resting state activity. So now I'll introduce the technique of DCM. So based on these responses that occur from the task at a source level, or the functional level, we can actually identify regions of interest that are in play. And DCM is basically a biologically informed framework. The sort of history behind it, brief history, is a bunch of biologists, a bunch of neuroscientists, and a bunch of mathematicians got together and decided, well, hey, let's do some mathematics behind the brain. And they came up with this framework that basically tells us a lot about how brain activity can be predicted. And in particular, when people are responding to tasks, it can be characterized. And we can also measure the strength of connections across the brain regions. So in the context of this study, we can actually map out how we're perceiving activity from all the way from the visual area to, and then from the higher order executive functioning, we can see how that maps back to lower levels of our brain as well. So it's really trying to map higher and lower levels and trying to predict which connections are stronger and which connections are weaker. And so forward connections in this sort of framework looks at language perception or attention. So we can actually map on when they're looking at a picture or they're processing a word, what kind of pathways are associated with it. And then for backward connections, looking at things like word retrieval, comprehension, and intrinsic connection, looking at the adaptation to language processing. So again, it is quite complex, but then what I hope from this study is that in coming up with a lot of models, we can actually take these models to any therapy setting or any particular task paradigm and test them out as well. And for this study, we came up with 24 models. They were basically variants of this idea of dorsal and ventral stream processing in language. And you can isolate just dorsal processes or ventral processes, or dorsal and ventral. And I think you might be familiar with the dual stream idea of brain processing in language. And what we found from our study was that healthy and aphasia participants actually have very, very similar cortical models of activity. And we found that the key difference in aphasia subjects was that the connections that we modeled were actually weaker, and that they were missing this key connection here. So this is what's shown for the healthy controls. They have this long connection connecting our visual area all the way to the very higher order level inferior frontal gyres. But they were missing this sort of adaptation to language processing. And that in itself was an exciting finding, because we sort of associate language impairment having a very different sort of pathway, or different constrained brain pathways, but they actually belong in this particular data set to the same model. And that allowed us to see which connections were becoming weaker and which connections were actually predictive of improvement. So the next step from this was to look at the correlates with the outcomes. And so there's quite a bit going on here in terms of these graphs, but the key thing is that the dotted line on each of these three graphs indicates task engagement. So those below the line were engaging less with the task, and then those above the line were engaging with the task. And then we looked at this pre and post therapy. And what we found was that pre-therapy, those that improved the most had higher task engagement in left hemisphere areas. And in right hemisphere areas, those who improved the most as well had lower task engagement in those areas. And we also found that those who improved the least actually had lower task engagement pre-therapy, but following that therapy, they did have a bit more connectivity in the left hemisphere. The second finding was that the right hemisphere was actually dominating in those who improved the least in each of these components as well. A lot of our significant findings was actually from semantic feature analysis, but there was a finding in phonological component analysis as well. And that indicated this role of overactivation, some sort of compensatory role, perhaps, of the right hemisphere. So in summary, really what I'm trying to show here is that DCM using EEG as well can really be integrated into a therapy setting, I think. And by characterising these responses pre and post therapy, we can actually target aphasia patients towards distinct naming treatments. There are, of course, some limitations of the study, sample size being one of them. We hope that we can translate this to a larger population and really try and address this variability problem. Again, the bias towards semantic components rather than phonological. This may just be a combination of the treatment paradigms that were utilised and also the task itself. And what we didn't do was map the EEG activity to lesion mapped areas in MRI, but this is something that we've marked for the future, and it can only improve the characterisation of EEG as well. And I'll just leave it on a concluding note about the lesion mapped areas, is that I think in particular those remote settings or settings where there's no access to MRI, using this technique I think is quite feasible with EEG.
So we have time for perhaps one question.
Kartik, you are doing a brilliant work. I would like to ask you, have you worked on functional resting state MMRI and the EEG correlation? Because few of the children with epilepsy, when I see, the EEG are not robust in terms of their artifacts and the functional compensation. And we don't get language fMRI because they don't cooperate in the language fMRIs. So the resting states have been just coming with the correlation of QEEG, qualitative spectrum analysis spectrum. Our center don't have the access, but we can get. But if you have any comment or any work with the biomedical engineering background on that.
Using
the resting state and the EEG correlation.
Yeah, so I think for this particular data set, we didn't have too much access to resting state for EEG, but for resting state for MRI, we do have that data. So I think in the future, we definitely want to relate and combine EEG with fMRI as well.
Thank you. Great study.